My name is Domellöf, and I will talk about the enteral nutrition, and I will focus on very low birth weight infants. And if we talk about enteral nutrition or small preterms, most people, the parents and many other people, will think it's just very cute. Everybody will think, oh, this is really nice, they get the enteral nutrition. But neonatologists have a completely different reaction. They always think about NEC, necrotizing enterocolitis. They always think about that. We always think about that every time we prescribe enteral nutrition to babies. And what we have to remember is that even though NEC is a very serious adverse event in preterm babies, it affects on average only about 5% of very low birth weight infants, and it does not affect 95% of very low birth weight infants. So we should not let that affect the 95%, because due to fear of necrotizing enterocolitis, we see in most hospitals, I would say, a delayed introduction of enteral feeds, a slow advancement of enteral feeds. We see interruptions of enteral feeds, and we see also prolonged use of parenteral nutrition, which in turn will lead to problems with sepsis, etc., and catheters. And we see also that you don't dare to give enough amounts and enough fortification of the enteral nutrition, which is resulting in insufficient enteral nutrient intakes. So we have to handle this, and we have to get rid of this unnecessary, in many cases, fear of NEC. And what is the basis for this fear? Well, as we know, enteral feeds is a causative factor in necrotizing enterocolitis, because we almost never see NEC in preterms who have not received enteral feeds. However, enteral feeds is not the only prerequisite. First of all, generally you would say that the infant needs to be preterm, and also there is some bacteria involved, and there might be other factors that we are not aware of. But certainly enteral feeds are involved in the causation of NEC. However, enteral feeds have also been shown to be beneficial. In animal studies, it has been shown enteral feeds are crucial for gastrointestinal development. They provide nutrition to enterocytes, and enteral nutrition stimulates secretion of growth factors and GI hormones. We have to remember that the fetus is consuming all the time enteral feeds in the form of amniotic fluid, and that does these things. Also, enteral feeds activates gastrointestinal neural pathways, and it has been shown that absence of enteral feedings leads to GI mucosal atrophy and dysfunction. And there were some studies already in the early 1990s by Caroline Boseth showing that early provision of enteral feeds day 3 to 5 versus day 10 to 14 improves gut function in preterms. So I will discuss now what is the evidence regarding, because the basic questions we have to put to ourselves is when to start with enteral feeds, how fast to advance, and what to feed the baby. And if you start with when to start, there is a very recent Cochrane review from this year by Morgan et al., who has put together all the studies comparing early minimal enteral nutrition before or after 4 days of life. And minimal enteral nutrition in this case and in many other cases is defined as less than 24 milliliters per kilogram per day. And these were 9 randomized controlled trials. They were not blinded for obvious reasons, with 754 babies. And in this Cochrane analysis, there was no effect on necrotizing enterocolitis, meaning no difference to start before or after 4 days of life. However, early starting of feeds reduced the time to full enteral feeds and reduced the need for parenteral nutrition. So that's a good thing, but there was actually no effect on growth or other health outcomes. So really, Cochrane analyses are really great, but sometimes they don't give us so much evidence. So we have some evidence that is probably not dangerous and probably an advantage to give minimal enteral nutrition before 4 days of life. What about the SGA infants? Because you know that SGA infants, especially those who had abnormal umbilical artery Doppler flow on the fetal ultrasound, they have an increased risk of necrotizing enterocolitis. And there was a very nice British study by Alison Leaf and others, the ADEPT trial, and with 400 infants randomized, and they had these risk factors, and they were randomized to start feeding on day 2 or day 6. And similarly to the Cochrane analysis I showed previously, there was no effect on NEC, and early feeds reached full feed sooner, less parenteral nutrition, and less cholestasis, which is a good thing. So there is not much evidence. This is all the evidence we have actually from randomized trials, and it seems that there is an advantage to start enteral nutrition during the first 2-3 days of life. And I think that it hasn't been really studied in many randomized controlled trials, but I think there's a widespread practice, at least in Sweden, and I think in many other places, to start on the day of birth. Can we have a show of hands? How many would start enteral nutrition on the first day of life? Yes, okay, that's great, because I think that's the way. Even though we don't have the evidence from randomized controlled trials, I think that animal experiments and other things show that it's probably good to start with minimal enteral nutrition as soon as possible. And then comes the more difficult question, is how fast to advance the feeds. And there's also a Cochrane analysis for this. And they included 5 trials with 588 infants, less than 1,500 grams or less than 32 weeks. Minimal enteral nutrition was started at day 1 to 5, and then they were randomized either to slow, meaning 15 to 20 milliliters per kilogram per day, or fast, which was 30 to 35 milliliters per kilogram per day advancement. And there was no difference in necrotizing enterocolitis or mortality between these 2 groups. However, the fast advancement group, they did regain birth weight and establish full enteral feeds more rapidly. So that's a clear advantage of the fast advancement. The only problem I have with this study is that if we should advance feedings at this speed, would mean that we should achieve full enteral feeds in 4 to 5 days. And this is probably, or this is very realistic in the little larger preterm babies, but we don't see this very often in the smallest preterm. And actually, in this Cochrane analysis, there were few studied infants less than 28 weeks or less than 1,000 grams. And these, we know that these are more difficult. They have more immature gastrointestinal tracts, and they will typically not achieve full enteral feeds until several weeks of age. So then we have to look at what we do in the clinical practice, that we look at something we call feeding intolerance. And this is a notoriously difficult to define concept. We all know that abdominal distension is extremely common in very low birth weight infants. They all lie there and they have the CPAP and they swallow air and they have very weak abdominal muscles, so they all get a distended belly with intestines full of air. And there was a very nice study by Walter Mihatz and others in Germany showing that in extremely low birth weight infants, meaning less than 1,000 grams, there was no correlation between feeding intolerance, which in that case was defined as a low feeding volume at day 14, and gastric residuals more than 2 to 3 milliliters or 4 milliliters per kilo, or bile-colored green gastric residuals. And this is kind of interesting because this is, we usually in the clinic, we would typically look at these things every day, and we would say that if the gastric residual is this and that large, this baby has a feeding intolerance and we should stop feedings or reduce feedings. But this study showed no correlation actually between that and an outcome on day 14. And neither we also look at the color. The nurses come and say, oh, this is a very green and ugly gastric residual. We should probably stop feeding. But there was no correlation either with that. And actually, the infants who did develop NEC in that study had a mean gastric residual volume of 1.2 milliliters the preceding 24 hours. So actually, there was no clue that these infants were developing NEC. It didn't seem that we could predict NEC by looking at the gastric residuals. So actually, gastric residuals seem to be pretty much worthless, unfortunately, because we measure them all the time, right? So what we can learn from this is that if gastric residuals are more than 4 milliliters per kilo or more than 50% of the last meal, it's not, according to this study, not always necessary to withhold feeding. You should assess presence of other signs. And what are the really severe signs of feeding intolerance? Well, that would be, of course, vomiting or severe abdominal distension with discoloration or absent bowel sounds, suggesting a peritonitis or blood in stools. And these are really severe signs. We don't very often see these signs, but these we very often see. So, how fast to advance? It's really difficult to answer this question. As fast as tolerated, we usually say, and probably faster than most of us currently do, right? And those more than 1,000 grams, we could possibly aim for the Cochrane result, which was around 30 milliliters per kilogram per day, which is a really rapid advancement of feed. Those less than 1,000 grams, I think we should be more careful because there's no data from randomized control trials. We should probably aim for 15 or 20 milliliters per kilo per day, but there's very, Richard suggested 12, right? Yeah, so we should probably be somewhere there, but there's very, very poor evidence. We don't have any evidence. But the thing, an important point is probably to avoid unnecessary withholding of feeds, because if you withhold feeds and you don't compensate, the babies will be even more malnourished. And then we come to the last questions, what to feed? And as we all know, human milk is the gold standard for enteral nutrition. It contains not only nutrients, but it also contains a lot of bioactive components which are not present in formula, including probiotics, actually. And what has been shown quite convincingly is that feeding human milk rather than infant formula decreases the risk of necrotizing enterocolitis by a factor 2.5. So that's, I would say, the absolute main reason why which is best proven also that we should use human milk. However, there's only limited data on fortified human milk. And then, of course, we can worry that if we fortify the milk with a powder or a solution which is based on bovine milk, we are actually making the human milk more like formula, and it might have less of a protective effect against NEC. But the data, anyway, as far as we know, overall suggests that human milk is to be preferred. And then the second main thing that we really have a lot of data supporting is that human milk improves neurocognitive outcomes. And this has been shown in a lot of observational studies. However, many of those observational studies can be biased with other factors affecting human milk feeding or breastfeeding. It has not really been convincingly shown in randomized controlled trials in preterms. Usually the Lucas studies, the Alan Lucas studies are referred, but they actually did, they showed that human milk feeding does not make cognitive outcomes worse, even though the babies were malnourished. So that's maybe an indirect evidence, but they actually didn't show an advantage. There's one cluster randomized trial in terms. It's the PROBIT trial in Belarus by Kramer et al., who randomized hospitals to promote breastfeeding or not. And they actually did see a significant effect on cognitive outcomes in school age. So these are the two main reasons why we recommend human milk. And then which human milk should be used? So then we have the own mother's milk and we have donor milk. And own mother's milk is theoretically the best. It contains all the bioactive components and the probiotic bacteria if it's not pasteurized, of course. However, we have the problem of CMV, seropositive mothers, and there has been some data. It has been very nicely shown that CMV can be transferred from the mother to the baby via breast milk. However, it's not really known how dangerous that is for the preterm baby. For the term baby, we think it's not dangerous at all. For the preterm, we really don't know. And there's probably not a reason to pasteurize for this. But this is not really a clear, we don't have clear evidence here. Do you pasteurize breast milk of CMV seropositive mothers? Does anybody do that? 1, 2, 3. Okay, so it's not so common. Okay. But the thing is, if you use the own mother's milk, if you want to really use the own mother's milk, it doesn't happen automatically. You actually do have to have a really good organization in your unit to give early and very active breastfeeding support because if you don't do that, you will have a lot of mothers who actually never really start pumping, and they never really produce milk, and so then you will have no supply of mother's milk. So you really have to remember that. Donor milk is very good, and most of the studies actually showing this NEC effect on NEC was done with donor milk. However, donor milk has to be pasteurized for safety reasons, which inactivates some bioactive components. And donor milk requires that you have an organization and that you have a breast milk bank in your organization, and not all hospitals do have it. Can we have a show of hands who have a breast milk bank in their hospital? Okay, so that was a little less than half. So then I would like to show an example of a preterm, a 26-weeker with a birth weight of 850 grams, who is now 1 month old and who has a current weight of 1,500 grams. And the baby, so it has been growing rather okay. And it's currently fed 30 milliliters 8 times per day by his or her mother's own milk. And we assume that the mother's milk has an average nutrient content of mature breast milk. This will result in a fluid intake of 160 milliliters per kilo per day. And if you do the calculation, we see that the energy intake is 112 kilocalories, which is not great, but it might be okay. Hello, Hans. Welcome. So we wonder, is this okay then? Is this a good diet for the baby? What do you say? Yes or no? Gets the fluid, gets the energy. What could we ask for more? Hello, speak up. What? You need more. More of what? More energy. Yeah. Really? Is that the big, more protein? Okay, yeah. So this is what we use in many Swedish hospitals now is this computer system, which actually makes it a little visual, what the babies get. So you see if it's green in the middle, it means that it's according to the recommendation. If it's red or yellow to the left, it means that it's a little less or a lot less than the recommendation. And if it's to the right, it's too much. But nothing is too much here. So what we see here very clearly is that this baby gets too little of protein. It only gets 2.2 grams of protein per kilo per day. It gets too little of some salts, sodium, for example, and some minerals, calcium, phosphorus, and also zinc and many vitamins. It's less than the recommendation. So how do we solve this? How do we supply this to the baby? Yes, a human milk fortifier. And if we add this, we can see that now we can achieve good nutrient intakes and actually for most nutrients. So that's the basis for using these multi-nutrient human milk fortifiers. But what is the evidence that we actually it improves the health of the babies? Well, there's a Cochrane analysis for that also. There's a Cochrane analysis for almost everything. And it has been shown to improve growth in very low birth weight infants, which is nice. It improves weight, length, and head circumference, not least important, right, because we think it reflects brain growth. However, there is insufficient data regarding neurodevelopmental outcomes, bone density, or other health outcomes, which actually what we are really most interested in. Importantly, it has not been shown to cause adverse effects, which is kind of surprising because if we add, we should expect some sort of abdominal problems if you add this much fortifier. But it has been, importantly, it has not shown to increase NEC even though that is always discussed on the ward rounds, that the fortifier might cause NEC, but it hasn't been shown. But probably, maybe the data is not enough here, but this is what it shows. And we believe, and also the Cochrane analysis believes, that it's currently unethical to perform trials using unfortified breast milk in very low birth weight infants. So what we have to do now is to figure out the best composition of this multi-nutrient fortifier, and we can compare two fortifiers against each other. That's what we can do now, because it's very clear that not fortifying, you will not at all meet the nutritional targets. When you fortify breast milk, you have to remember that all breast milks are not equal. These are two breast milks, and you can just visually see that they are not equal. And this is we will present some data later. Elizabeth will show in a poster that there's a huge variation here in the amount of protein. This is age of postnatal age date, and this is the amount of protein. So it varies from 3 to 1, and it also varies with time. And also the amount of fat, it varies even more. It's from 1.5 to almost or more than 6 grams per 100 milliliters. So that's a huge variation in nutrient content. And when we calculate with average nutritional contents of breast milk, we have to be aware of that. And in Sweden, we have been using individualized fortification based on breast milk macronutrient analysis already since the 1990s. This was pioneered by Stefan Pohlberger, and it has been shown in some studies that standard fortification fails to meet recommended protein intake in 50% of cases. In addition to a variable dose of human milk fortifier, extra protein supplement or fat supplement may be needed in individual mothers depending on their individual breast milk composition. So then we have basically two choices of nutrition of very low birth weight infants in the NICU. We can use a breast milk plus a human milk fortifier, or we can use a preterm formula if we don't have available breast milk. And the human milk fortifier is usually, as I said, based on bovine milk protein. Now, there are some very interesting data, a study by Sullivan et al., which I will not go into detail, which has used the human milk fortifier based on human milk, which, of course, theoretically would be even better. However, I would say that the study showed a less incidence of NEC in the group receiving the human milk-based human milk fortifier, but I think this needs to be confirmed by other studies before we can really trust that. And also, this product is not widely available in Europe currently. What about preterm formula? Well, it has preterm formula is, of course, then similarly a fortified version of the standard infant formula. And it has been shown to be superior to standard infant formula with regard to growth. And it has also been shown in some early studies by Alan Lucas that it actually results in less cerebral paresis and higher verbal IQ in boys at 8 years of age. So these are basically the options that we do have. And then I would like to discuss the 4 phases of preterm nutrition. And interestingly, this slide is almost identical to the one that Richard showed. We have 4 phases. We have the total parental nutrition phase, which is really, really short, as we said, like 0 to 3 days or something, if we start minimal enteral nutrition and then start increasing enteral nutrition. And then we have quite a long period of combined parenteral enteral nutrition, and then we have the full enteral nutrition, and then we have the post-discharge nutrition. And I would like to focus, well, Hans will talk about this bit, and I would like to focus on this period as a problem period. And I would like to show some data from a Swedish national study with 600 extremely preterm babies with an average gestational age of 25 weeks and birth weight of 765 grams. This is the EXPRESS study. And we have shown in a recently published paper this is the nutrition intakes, and this is the first week, this is the week 2 to 4, and this is after 4 weeks. And what we can see here, is that the enteral fluid intake during the first week of life in these extremely preterm babies, averaging 25 weeks of gestational age, was 27% enteral fluids in the first week, so mostly parenteral nutrition. That's expected. But the following 3 weeks, the babies received only 68% enteral fluids, meaning that they still have, and if you split it up in the weeks, we can see that actually during all of the first 4 weeks, the babies on average received a quite significant amount of enteral nutrition. So this advancement of enteral feeds was pretty slow. It was about 4 weeks on the average in these babies. Then after 4 weeks, we see 93% enteral fluids, so that's when they are really enterally fed. And what we do see is now, we haven't discussed so much about recommended intakes. We discussed that more in the afternoon, but there are different recommendations for energy intake: 110 kilocalories per kilo per day according to ESPGAN, 130 according to the Zhang textbook, and protein should be around 4. So if you look at the energy and protein intake here the first week, we can see it's really low compared to the full enteral recommendations. But still, during this period, the following 3 weeks, the energy intake was on average 114, which means that at least a significant proportion of these babies received less than the recommended energy intake, and more than half of these babies received less than the recommended protein intake, even during this period where they received a combined enteral-parenteral nutrition. And we did see a poor growth. This is the first 28 days. And the babies lost in standard deviations in weight, 2.1 standard deviations, 2.3 in length, and 1.5 in head circumference. So this period is of variable length when they receive a combination of PN and EN. As we shown, 25 weeks is maybe the first 28 days of life. In the 29 weeks, it could be around the first 10 to 14 days of life, as shown in a recent publication by Miller. And this period often results in accumulated energy and protein deficit. So how do we tackle that? Well, we have to advance enteral feeds rapidly, as rapidly as possible, as we discussed. But we have also to continue parenteral support until full enteral feeds. Richard discussed a paper where they had stopped the parenteral nutrition when babies were up on half enteral feeds. That means that the babies, of course, inevitably will be undernourished for some period. And also, which Nick also mentioned, it's important to actually calculate the energy and protein intakes. And you should be able to do that on a daily basis in these babies, risk babies, during this risk period at least. And then what we have discovered is that really to achieve the proper energy and protein intakes, we need to start fortifying earlier than we did. Previously, we waited until the babies were on full enteral feeds before we started human milk fortifier. Now, most units in Sweden would start at around 50 milliliters per kilo, 50 to 70 milliliters per kilo of enteral intake. And then we should also avoid unnecessarily withholding or stopping enteral feeds, which is a very, unfortunately, common practice. So these are the periods, and we have discussed this problem period number 2. And during this problem period, we often see that the babies have a poor growth. This is just an example baby here. But during the next phase, when the babies are on full enteral nutrition, what we often see is that the babies have a really nice growth, and they make a really good catch-up growth. And then another question which I often get is that why do we worry so much? Why do you insist that we should feed these babies more? Because they will only get obese, and they will get diabetes and hypertension and cardiovascular disease. And I think we really have to divide these two phases, because this phase is really where I think the problem is. And this phase, I think that we could actually have sometimes the opposite problem, that they maybe catch up a little more rapidly than we would like. We don't know how fast babies should catch up. What we can see here also is that the weight has a tendency to catch up much faster than the length. This blue line is the length The length has a delay of at least 2 weeks in catch-up. So at the term age, you will see that the baby are very short for their weight, which means that they have a high fat percent. And that has been shown in repeated studies that preterm babies have a high body fat percent at term age, here shown in a P-pod for body composition measurement. But just to summarize, I would say that we can very easily divide babies. Those very low birth weight infants in less than 1,500 grams, you would not be worried about overnutrition in those babies. They generally are undernourished, and they have a problem with undernourishment and brain development. However, those with a birth weight of more than 2 kilograms, they have a higher risk of overnutrition probably if you overfeed them, and then you can be worried about cardiovascular disease. What about these between 1,500 and 2,000 grams? I don't know. They are probably in between. And when we give the full enteral nutrition in the NICU, we have to give macronutrients and aim for the growth parallel to the intrauterine growth chart or a slow catch-up. And what is a slow catch-up? Probably not more than 1 standard deviation per month. Then we have to think also about micronutrients. And one micronutrient, which I'm especially fond of, is iron, so I cannot not mention it. It's required, as we know, for heme synthesis, but it's also essential for many enzymes. And it has been shown to be essential for many aspects of brain development, including myelin formation. We recently did a trial in low birth weight infants with a birth weight between 2,000 and 2,500 grams, giving 0, 1, or 2 milligram per kilogram of iron from 6 weeks to 6 months. And we actually, when we followed up these babies at 3 years, we found a significantly increased risk for behavioral problems in those that did not receive iron supplements. These are the unsupplemented babies, and this is the 1 and the 2 milligram group, and this last bar is a control group of normal birth weight infants. So this suggests that providing enough iron is important, and also generally it proves the hypothesis that not only the early macronutrient intakes, which has been discussed, but also the micronutrient intakes can have important long-term consequences. And a good take-home message from this study is to remember to prescribe iron drops to all infants with low birth weight, meaning less than 2,500 grams. And why is iron special in preterms? Well, first of all, neonatal iron stores increase initially because the hemoglobin drops and the iron is transferred to iron stores. And furthermore, there is no mechanism for iron excretion in humans, so as you know, there's always a risk of iron overload. And then to complicate things, in NICU session with very low birth weight infants, there's a significant amount of non-nutritional iron output and input, meaning that when we take a lot of blood samples, we will reduce iron, and when we give blood transfusions, we will supply a lot of iron to these babies. And this is just to show that. This is some random ferritin samples from our unit in very low birth weight infants. Here is ferritin. You see between 35 and 300 is the normal range for term babies, and you see that many babies have several thousand in ferritin here because they have received a lot of blood transfusions. And some babies are actually below 35, suggesting that these babies are iron deficient. So local practice regarding cord clamping, blood sampling, blood transfusions, and EPO treatment will influence iron requirements in very low birth weight infants, and also it will be a very different needs individually in these babies due to these risk factors. We have recently published a recommendation in Journal of Pediatrics this year, and suggesting 2 to 3 milligram per kilogram per day of iron from 2 weeks postnatal age. But before you start, check serum ferritin that it's not more than 300 micrograms per liter, especially if the babies have received blood transfusions. Otherwise, you should probably wait until it goes below 300. And then it's a good recommendation to follow serum ferritin regularly, for example, weekly. If serum ferritin falls below 35 micrograms per liter, you should increase the iron dose to 3, 4, possibly 6 milligram per kilogram per day. So how many actually do check ferritin in your NICUs? Oh, well, what was that? 20% maybe. And then I will just mention very briefly about novel enteral supplements that you can give. And probiotics was mentioned previously. It has been shown actually in a Cochrane analysis that it does prevent necrotizing enterocolitis and all-cause mortality in very low birth weight infants. They say in this analysis there is a lack of data in extremely low birth weight infants, and it's also unclear which preparation of bacteria to use. So there's currently some units have started using this and some have not, and yeah, so this is a discussion which could take a whole day. I will not go into it. We can have a raise of hands for that. How many use probiotics to prevent NEC? Yeah, that was also around 20%. Then a really interesting new thing is lactoferrin. There was, as you know, maybe know, a very nice Italian trial, randomized controlled trials in 472 very low birth weight infants using a supplement with oral bovine lactoferrin, and showed that it did reduce late onset sepsis, actually a risk ratio of 0.27, which is potentially a very important finding, but it's a single study and there are other studies ongoing. I think NIC is involved in one to see if this is really true. Then I would just briefly like to mention the fourth phase, which is the post-discharge nutrition. And I continue with this case of an infant who had a rather poor growth, but not too poor here in the beginning, and then a very rapid catch-up, and then the infant, during this period, the baby was fed breast milk and human milk fortifier, and then the baby was discharged, and it was breastfed and bottle-fed pumped breast milk, which was not fortified, and received iron drops and multivitamins, which is the common thing that everybody does. And this baby dropped a lot here in weight and also in length, not in head circumference though. So you can really wonder, was this an optimal management? Maybe this baby was overnourished actually during this period, maybe an unnecessary catch-up here, and maybe this is not very good physiologically to go through these starvation, overnutrition, starvation periods. What about breast milk or fortified breast milk? Here, NIC and others have done also a Cochrane analysis saying that there is not sufficient evidence currently for fortification, but there is one study, a Canadian study, actually suggesting a benefit for growth. So the data is not really conclusive here. Probably it's not a thing that should be used for all babies. Maybe you should identify risk babies and give fortification to those. And then another question is, if you give if the baby is formula fed at discharge, should you give a standard formula or a nutrient-enriched formula? There was also a very nice Cochrane analysis of this, showing that a post-discharge formula having about 74 kilocalories per 100 mils, there was no consistent evidence of improved growth up to 12 to 18 months, but using a preterm formula with more nutrient fortification, there was evidence of improved growth up to this age. So this study actually suggests that it's better to give a preterm formula than a post-discharge formula. Preterm formula is a little more nutrient enriched. However, there was no evidence for improved neurodevelopment by these interventions. So we really don't know which is the best for neurodevelopment. A pragmatic approach here is, as I see it, my personal view is that the babies who are at risk for poor growth are those that are not able to self-regulate their energy intake, because a normal healthy term baby is able to very well self-regulate the energy intake, and also an ex-preemie who is now healthy infant is supposed to do that as well. But so you should probably try to identify those babies who are not able to self-regulate. And I think the risk infants are those that are discharged early, meaning before 36 weeks, and if they weigh less than about 2,300 grams at discharge, or if they have known feeding problems. Sometimes you know that this baby has a feeding problem. What all babies should receive is iron drops, as we mentioned. All babies should also receive vitamin D, because we give that also to the term babies. However, if babies should receive multivitamins post-discharge, we don't know because there are no good studies. Many babies do receive multivitamins, and that's probably not dangerous. We should probably have a much better follow-up of risk infants than we do. And I don't know how you do in your centers, but in Sweden, this is a notorious problem because they are discharged and then somebody else is following up these babies, and they don't really have any knowledge about this. So you should actually, if you have these risk babies that I mentioned, you should probably follow growth at least weekly until adequate weight gain on a growth chart, meaning that they grow at least parallel on a growth chart. And if they don't grow well, if they lose standard deviations or percentiles, then you should consider these interventions, meaning fortification if they are breast milk fed, or preterm formula, or possibly post-discharge formula if the babies are formula fed. And the goal is, of course, that the babies grow up and are really healthy and smart and can discover new elementary particles that are awarded the Nobel Prize. For there must be something more than the Higgs boson, right? Thank you very much.